Malnutrition refers to deficiencies or excesses of nutrient intake or imbalance or impaired utilization of essential nutrients. This presentation will focus only on the diagnosis and treatment of undernutrition. Undernutrition manifests in four broad forms: wasting, stunting, underweight, and micronutrient deficiencies. Undernutrition can both be caused by a primary deficiency in intake or as a secondary effect of an underlying disease. However, undernutrition can also increase the risk of developing diet-related non-communicable diseases. Combating malnutrition in all its forms is one of the greatest global health challenges. Women, infant, children, and adolescents are at the highest risk of malnutrition. In 2022, 140 million children under the age of 5 were estimated to be stunted, 45 million children were estimated to be wasted, and 37 million were estimated to be overweight. In 2022 alone, approximately 7.3 million children received treatment for severe acute malnutrition, or SAM. Moderate acute malnutrition, or MAM, and SAM are primarily a problem in resource-limited settings, especially in South Asia, including Afghanistan, India, Pakistan, Bangladesh, Nepal, and Sub-Saharan Africa. Severe and moderate acute malnutrition are not common in North America, Australia, and other resource-abundant settings. Although treatment coverage has increased, children with severe acute malnutrition in many of the worst affected countries are still unable to access the care necessary for them to recover. Many more children, approximately 150 million worldwide, have stunting from chronic undernutrition. The prevalence of stunting has gradually declined in most regions during the past 3 decades, likely a result of improvement in education, socioeconomic status, sanitation, access to maternal health services, and family planning. Nonetheless, the prevalence of stunting remains unacceptably high in the previous discussed regions. Optimizing nutrition early in life, including the 1,000 days from conception to a child's second birthday, ensures the best possible start in life with long-term benefits. Much of the guidance around diagnosis and treatment for severe acute malnutrition is thus directed at children between 6 months and 5 years. Poverty amplifies the risk of and risks from malnutrition. People who are poor are more likely to be affected by different forms of malnutrition. It should not be overlooked that malnutrition increases healthcare costs, reduces productivity, and slows economic growth, which can perpetuate a cycle of poverty and ill health. Individuals noted to have undernutrition can be classified as wasting, stunting, and/or underweight. Wasting is defined as low weight for height. It often indicates recent and severe weight loss, although it can also persist for a long time. It usually occurs when a person has not had food of adequate quality and quantity, and/or they have frequent or prolonged illnesses. Wasting in children is associated with a higher risk of death if not treated properly. Stunting is defined as low height for age. It is the result of chronic or recurrent undernutrition, usually associated with poverty, poor maternal health and nutrition, frequent illnesses, and/or inappropriate feeding and care in early life. Stunting prevents children from reaching their physical and cognitive potentials. Underweight is defined as low weight for age. A child who is underweight may be stunted, wasted, or both. Micronutrient deficiencies are caused by a lack of essential vitamins and minerals, even if enough food is consumed. This is because these essential nutrients are often not present in the diet, or they're not absorbed by the body properly. Micronutrients enable the body to produce enzymes, hormones, and other substances that are essential for proper growth and development. Iodine, vitamin A, and iron are the most important in the global public health arena. Their deficiency represents a major threat to the health and development of populations worldwide, particularly children and pregnant women in low-income countries. Iron deficiency is the most widespread micronutrient deficiency globally, affecting approximately 2 billion people. It can cause anemia, fatigue, and weakness. Vitamin A deficiency is a major public health problem, especially in Africa and Southeast Asia. It can lead to night blindness, increased risk of infections, and even death in severe cases. Iodine deficiency can cause goiter, a swelling of the thyroid gland, and an intellectual impairment in children. Severe acute malnutrition can be divided into clinical subtypes based on the presence or absence of edema. Edema is a condition characterized by an excess of watery fluid collecting in the cavities or tissues of the body. Malnutrition without edema is known as marasmus or wasting, and malnutrition with edema is known as kwashiorkor or edematous malnutrition. In the past, children with kwashiorkor were previously thought to have worse outcomes compared to those with marasmus, but more recent studies demonstrate that children with kwashiorkor tend to have better outcomes thought to be related to higher rates of comorbid HIV and diarrheal dehydration among those with marasmus. Marasmus is characterized by low weight for height and reduced mid-upper arm circumference, reflecting wasting of muscle mass and depletion of body fat stores. It is the most common form of protein energy malnutrition and is thought to be caused by inadequate intake of all nutrients, but especially dietary energy sources. The physical findings of marasmus include a head that appears large relative to the body, with staring eyes, an emaciated and weak appearance, an irritable and fretful affect, bradycardia, hypotension, hypothermia, dry, thin skin, shrunken arms, thighs, and buttocks with redundant skin folds due to loss of subcutaneous fat, and thin, sparse hair that is easily plucked. Kwashiorkor is characterized by symmetric peripheral pitting edema that begins in the most dependent regions and spreads towards the head as time progresses, often involving the far low back, genitalia, and eye area, with or without severe generalized edema. There is marked muscle atrophy with normal or even increased body fat. Malnutrition is considered severe if any edema is present, regardless of other measurements or proportions of the patient's body. The physical findings of kwashiorkor include an apathetic, listless affect, rounded prominence of the cheeks, pursed appearance of the mouth, thin, dry, peeling skin with areas of thickened skin and darker patches of skin, hair that is dry, dull, possibly lacking pigment that falls out easily, enlarged liver, distended abdomen with dilated intestinal loops, bradycardia, hypotension, hypothermia, and loose inguinal skin folds. Severe acute malnutrition affects many organ systems. The cardiovascular system. Children with either marasmus or kwashiorkor have precarious fluid balance. The infusion of saline may cause an increase in venous pressure and acute heart failure, whereas a decrease in blood volume can compromise tissue perfusion. In children with marasmus, cardiac output and stroke volume are reduced in proportion to the loss of lean body mass. Hence, the cardiac index, which is a hemodynamic parameter used to assess how well the heart is functioning as a pump, is normal and a false indicator of health. Some studies have reported that cardiac function measurements, including myocardial mass, return to normal in many patients with severe acute malnutrition by day 7 of hospitalization. The gastrointestinal tract. In malnutrition, the gastrointestinal system is affected in many ways. Production of gastric acid is reduced, and the pancreas doesn't produce enough enzyme to digest food properly, more so in children with kwashiorkor. Unfortunately, pancreatic enzyme replacement therapy does not improve weight gain. The mucosa of the small intestine becomes atrophied. Production of further downstream digestive enzymes is reduced, think lactase for milk products, and transport of nutrients across cell membranes is also reduced. Intestinal motility is reduced, potentially leading to intestinal stoppage. Chronic malnutrition weakens the gut lining, leading to damage of the small finger-like villi in the small intestine, a thinning of the lining of the intestine, increased intestinal permeability, abnormal accumulation of white blood cells, and a generalized imbalance of gut microorganisms. Hepatomegaly from fatty liver is common, especially in kwashiorkor. Hepatic gluconeogenesis, the process of the liver converting carbohydrates to sugar, is reduced in patients with low albumin, a protein found in blood plasma, which increases the risk of low blood sugar. Hepatic metabolism of toxins is also severely reduced in malnutrition, as well as protein synthesis. The genitourinary system. Renal function is significantly impacted in malnutrition, demonstrated by reduced ability to filter toxins out of the blood into the urine, to excrete sodium, and to excrete excess acid. Urinary tract infections are also common. Immune system. Immune dysfunction and infections are closely associated with malnutrition and are probably both the cause and consequence of malnutrition. Severely malnourished children are at extremely high risk for superimposed infections. There is general immune dysfunction in marasmus, largely due to alterations in the gut barrier and the imbalance of normal gut microorganisms. Glands of the immune system, such as the lymph glands, tonsils, and thymus, are atrophied. The size of the thymus is inversely proportional to the duration of malnutrition and improves with treatment. And although the acute phase immune response is intact, the typical signs of infection, such as increased white blood cells and fever, are frequently absent. Septic shock is often associated with low blood sugar and hypothermia. The endocrine system. In the endocrine system, insulin levels are reduced and the child may be glucose intolerant. Growth hormone levels are increased, as are cortisol levels. The central nervous system. Neurological changes are found in approximately 20% of children on brain MRI. In the majority of patients, these gross changes resolve with treatment. Metabolic and circulatory systems. The basal metabolic rate is reduced by approximately 30%, but rises markedly during the recovery period. The ability to regulate body temperature is impaired, so patients can easily become hypo or hyperthermic. Cellular function. On a cellular level, sodium pump activity is reduced, and cell membranes are more permeable than normal, resulting in an increase in intracellular sodium and a decrease in intracellular potassium and magnesium. Protein synthesis is also reduced. The skin and glands. The most external and obvious sign of malnutrition is the skin and body habitus. The skin and subcutaneous fat has wasted away, which causes loose skin folds. As a result, many signs of dehydration are unreliable. For example, the eyes may appear sunken because of the loss of subcutaneous fat in the orbit, and the children may have dryness of the mouth and eyes as well as reduced sweat production because of atrophied sweat, tear, and salivary glands. Malnutrition in disaster and humanitarian crises is a complex issue. Unfortunately, when responding to such environments, teams will likely have little to no role in prevention, but rather efforts will focus on mitigation and treatment. Focus on the first 1,000 days. This critical window from conception to age 2 is crucial for healthy development. Efforts should prioritize promoting and supporting breastfeeding exclusively for the first 6 months and continued breastfeeding with the addition of complementary foods up to age 2 or beyond to provide optimal nutrition for infants and young children. Further, ensuring good nutrition for mothers before, during, and after pregnancy is essential for their health and the health of their babies. Strengthen the food systems. A sustainable approach to food production and access is vital and should include supporting small-scale farmers, dietary diversification, and food fortification. Empowering small farmers, particularly women farmers, with resources and knowledge can increase production of nutritious foods. Encouraging the cultivation and consumption of a wider variety of nutrient-rich foods, including fruits, vegetables, legumes, and animal products where possible. And adding essential vitamins and minerals to staple foods like rice, wheat, or flour can significantly improve micronutrient intake. Social safety nets and economic empowerment. Poverty is a major driver of malnutrition. Providing targeted financial assistance to affected families can improve their access to nutritious foods. Educating people about healthy eating habits and the importance of micronutrients can empower them to make informed choices. Improved healthcare and sanitation. Early detection and treatment of malnutrition is essential. Having efficient healthcare systems to identify and treat the causes of malnutrition promptly is crucial. In addition, access to clean water and sanitation facilities reduces the risk of waterborne diseases that can impede nutrient absorption. These strategies need to be implemented in a coordinated way with governments, international organizations, NGOs, and local communities all playing a part. By addressing the root cause of malnutrition and promoting sustainable solutions, we can create a future where all children have the opportunity to grow and thrive. The mid-upper arm circumference, MUAC, is an accurate and efficient way to screen for wasting. It is especially valuable as field measurements in settings during which time, equipment, or trained personnel are limited, such as famines and refugee crises. A MUAC of less than 11.5 centimeters is used to define severe wasting in children 6 to 59 months of age. A single cutoff can be used because it is reasonably independent of age and sex in young children. This cutoff is fairly sensitive for detecting severe wasting. A MUAC less than 11.5 centimeters will fall in the red zone and should trigger immediate treatment or referral. A MUAC between 11.5 and 12.5 centimeters will fall in the yellow zone and indicates borderline or mild malnutrition. A MUAC of greater than 12.5 centimeters is normal and not indicative of malnutrition. These scores are a powerful tool used to assess nutritional status, particularly in children under 5 years old. This provides a standardized way to compare a child's weight, height, or head circumference to a reference population of healthy children of the same sex and age. The WHO growth standard uses Z-scores to define the normal and abnormal ranges for growth. A Z-score of -3 indicates severe acute malnutrition. To calculate the Z-score, use an online calculator and do the following. Find the correct table for the child's age, either 0 to 23 months or 24 to 59 months, and the sex, either boy or girl. Measure children 0 to 23 months of age or less than 87 centimeters long, lying down, which is the length. Measure children 24 to 59 months of age or taller than 87 centimeters standing up, which is the height. Find the figure closest to the child's length or height in the left column. move your finger to the right to find the range that contains the child's weight. The label at the top of the column with the range containing the child's weight tells you the child's nutritional status. While z-scores are particularly helpful when assessing the growth of a child whose height and weight measurements fall well below or above standard percentile values, the MUAC is a better predictor of mortality and is easier to perform and is not as affected by dehydration. Some children with acute undernutrition develop nutritional edema. Edema is an accumulation of fluid in the tissue, especially in the feet and legs, and nutritional edema is specifically characterized as being bilateral and pitting. Assess for pitting edema by using a finger to press down on the swollen area and examine the depth of the indentation. After you remove your finger from the indented area, note how long the indentation remains. Pitting edema is graded on a scale of 1 to 4. Grade 1 is less than 2 millimeters indentation and disappears quickly. Grade 2 is between 2 and 4 millimeters and lasts between 10 and 15 seconds. Grade 3 is between 4 and 6 millimeters and lasts more than 1 minute. And grade 4 is between 6 and 8 millimeters and lasts more than 2 minutes. Any sign of bilateral pitting edema, regardless of z-score or MUAC classification, is considered severe acute malnutrition. For a positive MUAC and edema, the diagnosis of acute undernutrition is clear and straightforward, and those who measure or check them would be immediately able to determine the child's nutritional status and refer accordingly. Treat unstable patients with underlying severe acute malnutrition for life-threatening emergencies with a systematic approach, and remember these special considerations. For patients with severe acute malnutrition and seizures or altered mental status, consider hypoglycemia and administer dextrose. For patients with severe acute malnutrition and signs of shock, give specialized fluids cautiously. 15 mL per kg bolus of a 5% dextrose-containing fluid can be given over 1 hour. Monitor closely for signs of fluid overload or worsening respiratory distress. Consider severe anemia and the need for blood transfusion. Treatment for malnutrition depends on the severity of the case and the person's overall health. However, all patients with severe acute malnutrition should receive nutritional treatment with enriched milks or foods. Protocols vary based on national guidelines and product availability, but close coordination with a nutritional center is necessary for long-term treatment. Consider types of patients require referral to a hospital or advanced care facility. This includes patients with anasarca, which is pitting edema from the lower limbs to the face, severe anemia, either tested with point-of-care lab or clinically suspected, comorbid malaria, pneumonia, sepsis, fever, or other infection, and severe symptoms such as persistent vomiting, shock, altered mental status, seizures, severe anemia, hypoglycemia, and severe diarrhea. Additionally, patients who do not have danger signs but fail an appetite test require urgent referral and transfer to a feeding center or hospital. The appetite test is specifically used to assess a child's appetite, particularly in cases of suspected malnutrition. It's important to note that this test should only be administered by a healthcare professional or trained caregiver. Here's a general overview of the process. To prepare, find a quiet, calm space for the test. Explain the purpose of the test to the child's caregiver in a reassuring way. Wash hands. To administer the test, the caregiver should sit comfortably with the child on their lap. A small amount of ready-to-use therapeutic food, like Plumpy Nut or BP100, is offered, either from the packet or on a finger. The caregiver gently encourages the child to take the food throughout the test. Water should be offered frequently throughout. It's important to note that the child should not be forced to eat. The healthcare professional will observe how much of the ready-to-use food the child consumes during the testing period, which can range from 15 minutes to an hour. The amount consumed helps assess the child's appetite and potential for recovery. Refusal to eat or poor consumption might indicate further evaluation or treatment is needed. Dehydration can be difficult to distinguish from septic shock and is strongly linked to increased mortality and must be treated carefully. Use oral rehydration whenever possible, as IV hydration can easily lead to overhydration and heart failure. Consider Risomal instead of ORS for children. Risomal is intended exclusively for people suffering from acute malnutrition. It must be used under medical supervision in therapeutic nutrition centers and must not be distributed directly to families. Severely malnourished children commonly have potassium deficiencies and other various mineral deficiencies, as well as abnormally high sodium levels. In the event of dehydration, they should therefore be given specific ORS containing less sodium and more potassium, as well as magnesium, zinc, and copper. Risomal has been designed to meet this specific need. It should not be administered to well-nourished people or those suffering from cholera. In some countries, packets of oral rehydration salts, or ORS, are available for mixing with water. These contain a simple mix of sugar, salt, citrate, zinc, and potassium. However, homemade drinks, especially cereal drinks, when correctly prepared, are often cheaper, safer, and more effective than ORS packets. Consider adding small amounts of fruit juice, coconut water, or mashed ripe banana if available to provide the patient with naturally occurring sources of potassium. Teach patients to consume home rehydration drinks in a timely manner so they do not spoil. Treatment for malnutrition depends on the severity of the case and the person's overall health. For stable patients, teams use ready-to-use therapeutic food, or RUTF, such as Plumpy Nut or BP100. RUTF is of high nutritional quality and is easily transportable, does not require cooking or other preparation, and has minimal spoilage. It provides all the micronutrients and macronutrients needed for nutritional rehabilitation. Plumpy Nut is used as treatment for emergency malnutrition cases and supports rapid weight gain derived from broad nutrient intake, which can alleviate impending illness or death in a starving child. The product is easy for children to eat because it dispenses readily from a durable tear-open package. The fortified peanut butter-like taste contains fats, dietary fiber, carbohydrates, proteins, vitamins, and minerals. BP100 is another brand of RUTF and comes in the form of a compressed biscuit or bar. BP100 can be consumed as is or crumbled into boiling drinking water and eaten as a porridge. Refeeding should start at 175 kilocalories per kilogram per day. For reference, RUTF is generally provided in foil sachets containing 500 kilocalories. Increased nutrition following a prolonged period of starvation can result in refeeding syndrome. Refeeding syndrome is defined as medical complications that result from fluid and electrolyte shifts as a result of aggressive nutritional rehabilitation. Refeeding syndrome commonly occurs in populations at high risk for malnutrition, ranging from patients with eating disorders to renal failure patients on hemodialysis. Metabolic disturbances manifest in cardiopulmonary, hematologic, and neurologic dysfunction in these types of patients. Hypophosphatemia is considered a hallmark of refeeding syndrome. However, other electrolyte irregularities may also include, but are not limited to, decreased amounts of magnesium, potassium, and thiamine. Despite the long-standing recognition of refeeding syndrome as a serious clinical complication with high mortality rates that require immediate medical intervention, high-quality scientific evidence on the etiology and management of refeeding syndrome is limited. Historically, early descriptions of this phenomenon date to documentation from World War II, when individuals living during the famine unexpectedly became ill following nutritional reconstitution. In 1951, Snedeker et al. Reports that 1/5 of Japanese prisoners starved in prison camps died suddenly after nutritional and vitamin replenishment. A registered dietitian can craft a personalized diet plan rich in calories, protein, and essential nutrients. This may involve consuming fortified foods with added nutrients and incorporating frequent snacks between meals. For those with difficulty swallowing, there may be modifications or use specialized nutritional drinks. Vitamin and mineral supplements are often recommended to address specific deficiencies. In severe malnutrition cases, hospitalization may be necessary, especially for children. This could involve nutritional therapy through feeding tubes or intravenous fluids to deliver essential nutrients directly and/or gradual reintroduction of food by mouth as the patient tolerates it. If underlying medical conditions are contributing to malnutrition, it needs to be treated concurrently to improve nutrient absorption and overall health. Many studies have shown a high prevalence of clinically significant infections among children hospitalized for severe malnutrition. This observation has led to treatment guidelines recommending the use of routine antibiotic agents, even for children treated as outpatients, although outpatients are presumably much less likely to have a systemic infection than are patients with complicated cases that require inpatient care. This recommendation for the use of antibiotics is based on expert opinion and has not been directly tested in clinical trials. And observational data suggests that antibiotics are unnecessary and perhaps even harmful in children with uncomplicated severe acute malnutrition. The WHO recommends that children between 6 and 59 months of age with uncomplicated severe acute malnutrition not requiring to be admitted and who are managed as outpatients should be given a course of oral antibiotics such as amoxicillin. Adding routine antibiotic agents to nutritional therapy may increase recovery rates and decrease mortality among children with severe acute malnutrition treated in the community. Children who are 6 to 59 months of age who are undernourished but who do not have severe acute malnutrition should not routinely receive antibiotics unless they show signs of clinical infections. Children less than 5 years of age are especially vulnerable to malaria, and approximately 61% of all malaria deaths occur in this population. Malnourished children are at higher risk for contracting malaria and dying from the disease when compared with well-nourished children. Severe acute malnutrition is associated with increased malarial morbidity in children in sub-Saharan Africa and may affect the pharmacokinetics of anti-malarial drugs. HIV infection and undernutrition often occur simultaneously, particularly in resource-limited settings, and malnutrition commonly affects children infected with HIV. HIV infection increases susceptibility to persistent diarrhea and opportunistic infections, which can greatly impact the health of severely malnourished children. It is known that children infected with HIV who also suffer from malnutrition are 3 times more likely to die during treatment when compared to their HIV-negative counterparts. Among the potential complications of malnutrition, one of the most important complications is infection, which contributes to the increased morbidity and mortality in these groups. Vaccination is very important in protecting undernourished children against life-threatening infections. The goal of vaccination is to produce long-term protection by generating memory cells and the generation of antibodies. Since malnutrition is a state of immunodeficiency, the immune response to vaccines in these children is a matter of concern. Studies suggest the polio, pneumococcal, H-flu, rabies, and cholera vaccines showed normal responses to immunization in undernourished children. Measles and rotavirus vaccines were found to elicit lower seroprotection and lower efficacy in undernourished children. The decision to discharge a patient from a treatment center hinges on clinical stability, caregiver ability to maintain proper feeding at home, and access to ongoing monitoring. In the setting of a day or mobile clinic, the determination of a patient's disposition should be focused on their stability. If patients are tolerating oral rehydration and food supplementation, with education and food resources, they can be safely discharged back to the community. Patients who are unstable or not tolerating oral supplementation should be identified early and transferred to fixed facilities who have longer-term treatment available. Regular follow-up checks and connection to community resources for continued nutritional support are essential for preventing relapse. In resource-limited settings, the focus should be on low-cost, locally available interventions, empowering caregivers, collaborating with community health workers, and advocating for improved access to basic necessities like clean water, sanitation, and healthcare. Malnutrition can disproportionately impact certain populations, and treatment plans need to be sensitive to their unique needs. Infants, young children, pregnant and lactating women, and older adults all have specific vulnerabilities due to growth stages, increased nutrient demands, or age-related challenges. People with chronic illnesses, mental health conditions, or disabilities may face difficulties with eating or absorbing nutrients. Those living in humanitarian crises or with limited resources often lack access to sufficient or nutritious foods. Tailored interventions, social support, addressing mental health aspects of food intake, and ensuring accessibility of treatment programs are all crucial for effectively combating malnutrition in these high-risk groups. The fight against malnutrition extends beyond simply providing food. Environmental factors significantly impact how well people are nourished. Lack of clean water, sanitation, and hygiene can worsen malnutrition, particularly through diarrhea in children. Climate change disrupts food production through droughts, floods, and extreme weather, leading to food insecurity and higher prices for nutritious foods. Environmental degradation, like deforestation and pollution, can reduce the nutritional quality of crops and contaminate food sources. To improve nutrition, we need to address these environmental challenges. Promoting sustainable agriculture, investing in WASH programs, developing climate-resilient farming techniques, and reducing pollution are all crucial steps towards a world where everyone has access to safe, nutritious foods. Safeguarding water, sanitation, and hygiene is critical for tackling malnutrition. Contaminated water is a major culprit, causing diarrhea that hinders nutrient absorption and dehydrates patients. Access to clean drinking water through treatment methods like chlorination or boiling is essential. Open defecation and improper waste disposal spreads pathogens that worsen malnutrition, so ensuring clean and accessible toilets is crucial. Hand washing with soap at times is key, especially before handling food and eating. It's a simple yet powerful way to prevent disease transmission. Food hygiene practices throughout the food chain, from storage to preparation, are also vital to prevent contamination. Integrating WASH interventions alongside dietary changes and micronutrient supplementation creates a comprehensive approach to treating malnutrition. Educating caregivers about WASH practices and their link to better nutrition is key for long-term improvements. Even in resource-limited settings, promoting simple wash practices like hand washing with soap can significantly improve health outcomes. The World Health Organization doesn't have mandatory reporting requirements specifically for individual cases of malnutrition. However, the WHO plays a crucial role in promoting global efforts to address malnutrition and monitors its prevalence through various mechanisms.